Lindsay, has anyone ever said they don't want it recorded? Like,
No, we
I
haven't
guess,
got that feedback.
I guess they don't get to choose, but I always find it funny. You have to,
I don't want it recorded.
well, they always ask, like, are you okay with it being recorded?
How come Katie's name's first?
It's not. It's middle.
Because
So I
she's
had to
fat.
put the slides together.
Oh, on here.
Good point.
Yeah.
You did all the work.
You're just the founder, Scott. Katie's got like the PI.
I think we kind of missed out. We should have went with a little bit more of a love theme for today.
We're not there yet. I still have my introduction. I was trying to figure out how to play something Barry Manilow or what's the other Barry? The other love song Barry something.
Or we should have went with, like the Beatles.
All you need
I
is
I
love.
was gonna find some love music, but I couldn't figure out how to play music on Zoom because headphones block it out.
Lindsay's figured that out.
Oh, I know. Lindsay's smarter than I am.
That's an understatement.
It would have been a little awkward. Everyone's logging in and they're like, "Love's in the air." Very white.
Thank
Very
you.
white. Very white. That's what it was. Not very. All right, so we're at 11 o'clock. Let's give this a couple more minutes of people are adding to the chat. Oh, hi. Hello, Katrina. Very white. Thank you, Randy. See? So Randy's all relaxed. He had a little sunny trip. His mind is clean. You can think of these witty things.
He's probably got Very White playing right now.
Everybody does. Yeah. Scott and I were talking about our Valentine's screw ups already. We're off to a bad start with our wives, but they put up with us this long. So. I know that I guarantee Katie had a good start because her husband is amazing. That is his prefix to his name is amazing. So I'm sure he is.
Every day is Valentine's at our house.
Every day. Flowers waiting for you.
Can I tell a quick story about Katie and her husband just to give people a sense for like every day is Valentine's Day?
I want to use his name. He could be in like the witness protection program or something, so I didn't use his name. So we'll just call him Amazing.
So Katie came out to the West Coast for a trip and her husband came with her. And so he went fishing during the morning while we did our work meetings, and then we met up for lunch. And they show up and they see each other and I'm not going to be able to recreate it, but basically it's like 5 quick repetitive kisses and like that. And I was like, what just happened? These people have been married for a long time. And I felt like I was back in junior high school. And so
it was sloppy. Yeah. It was
and
cute.
then I thought, well, I'll try it with my wife. And she showed up and I did that. And I thought she looked at me like, what is wrong with you?
She was struggling to get away.
Yeah, she was trying to push me away.
Best start to a fireside chat.
That's every day is Valentine's Day.
Oh, to continue the fish story. So he catches this beautiful fish and then sends me a hat, but he doesn't have my address. So he sends a Scott's house. It took 6 months to get that hat, but now I wear it all the time. It's beautiful. Beautiful hat. All right, guys. Today is our 2024 Fireside Chat kickoff. So we skipped January, gave everybody a little break, and we're going to roll right into our 24 series. And I think, thanks and compliments to Danielle and Lindsay, we've got a great lineup. So most of our speakers are already in place for the year. So we're well ahead of schedule in terms of getting that all figured out. So you should have good notification the month prior in terms of who's going to be a speaker for the following month. And as always, we record these things so you can always jump on and watch the recording or go back and watch any of the past I think we're on year 4 of this, so enjoy. But to start, as you can tell, love is in the air, especially for 6 Degrees cost containment solutions. Like that, Katie? PI specifically. and I couldn't ask for a more lovely panel of people to be doing this with. And I see Katie's got her pink on. I've got my pink on. When Danielle was on camera, she had hers as well. Scott claims that gingers cannot wear pink or red. So feel free to throw something in the chat on your opinion on that. But I think Scott would look good in pink or
Come
red.
on. There's got to be a ginger on this. You got to back me up here. No gingers got red in their closet.
I think you should try it. Anyways, usually we've got a outside guest doing our firesides, but once a year we do an internal staff fireside chat. And this one I thought was pretty important. When Katy came on, and I'll let her go through her background, but she brought with her an incredible wealth of knowledge in terms of her ability to see how you can handle these big claims prepayment. And that is something that we've built out that is being utilized on network plans across the country, both at self-fund level, carrier level. It's an incredible solution that they built, but we've also included that in our reference-based product. So that's what we're going to be talking about today. How these things can play out. We got Scott Ray. I'm sure many of you, if you've ever attended these, have had the pleasure of his dialogue. So he'll be contributing to this. And then Katy will get into the specifics on how it works within the PI environment. I'd also like to announce, almost like Oprah, if you are at the Southwest Washington live studio audience, you'll be getting some C's candies today. So keep your eyes open for that if you're in the background here. Which is my dog, my cat, and my kids will be home at some point, and then after I'll roll in. But anyways, that joke probably would be better with people's faces that I could see, because right now it just seems really quiet. So with that, I'm going to turn it over to Katy. It wasn't that good. I thought when I was thinking this morning, I was like, that, the live studio audience thing. Guess not. We're all virtual. Okay. Anyways, I'm going to turn it over to Katy, Scott, and we will go from here. So enjoy, everybody.
Yeah.
Oh, hold on. One more thing. Use your Q&A function at the bottom of the screen. I see the chat is going, but if you have a question, I'd much prefer you use the Q&A thing. That allows me to keep track of those things. I'll ask them as we go through the presentation, and Katy has asked for you guys to speak up after each slide so she can kind of keep everything compartmentalized. So, all right, there you go. Now I'm done.
So you want me to give a little background on kind of the origin of the PI? Just turn it over to you, Katy. Can talk a little about your background.
Sure.
So, I had the opportunity to meet Katy, gosh, I don't know, a few years ago now. And when we, one of the principles that I've lived by in growing 6 Degrees Health is you never pass up an opportunity to hire an exceptional employee. And if you have ever had the opportunity to spend any amount of time with Katy, it's like an hour or two, and you'll feel like she's your long lost sister. So she is first a phenomenal human being with a huge heart. And it's been wonderful having her as a partner. On a professional level, she is truly exceptional. Like she's been in healthcare, I think, longer than anybody at 6 Degrees Health. The other day, she referred to herself as the grandmother of healthcare, but I like to refer to her as the Taylor Swift of healthcare. That's truly a better label for her. But she's built payment integrity programs over the years, many of them. She has a phenomenal reputation in the industry, and that's evidenced by clients coming to us just because they're familiar with her background and what she's done, to work with her on payment integrity. And some people might think about payment integrity more in the network context, which it is critical in that space, but it's also very relevant in reference-based pricing, and it's been a huge addition to our product lineup. And and enhancing our reference-based pricing solution. And I think we truly are differentiated on this point. I don't think there's anybody that comes close to, to our capabilities on clinical review for payment integrity. And why it's important in reference-based pricing is because if you think about when a provider provides a service and they issue a claim, when that claim comes in, we're going to reprice it, and we're going to reprice it to either a contract if one exists, or we're going to reprice it to some sort of benchmark that's in the plan document, such as Medicare, maybe a cost plus, what have you. But regardless, it's going to get repriced. And it's kind of, I like to think of it as like the garbage in, garbage out principle, which is if you start with a problem claim and then you reprice it, a lot of times you're going to end up with problems. You're going to have, you potentially, even if you're repricing to a contract or to Medicare, you could end up paying more than you should because you didn't correct the claim to start with. And that's what payment integrity is all about. And that's what Katie's going to get into. And the only exception I can really think to where payment integrity might not be that important is in a case rate setting, but in a pure case rate setting. So like if you think back to the old transplant days where, somebody would offer up $100,000 case rate for a kidney transplant with no outlier thresholds, meaning it didn't matter if they billed you $2 million, you're still going to just pay $100,000. If you have that type of contract, which is extremely rare, but if you have that type of contract, then it doesn't really matter what gets billed because the payment has already been pre-negotiated. But for the other 99.99% of claims, this is extremely relevant. You could even make an argument there's some fiduciary issues if you're not engaging in some sort of a review of these claims. So with that said, it's an honor to turn it over to Katy. And I was just thinking, Heath, maybe next conference we could play off the Taylor Swift thing and do like friendship bracelets, for Katy or something like that. Just a thought.
Totally. So we're gonna do friendship bracelets in between two firms. That's the
Okay.
that's
Oh, don't
perfect.
get me started on that. That's a sore subject. We won't go there. Katy, you want to take over on?
Yeah. Thanks for the background, Scott, and the kind words. You're far too kind to me. But as you can see, love is always in the air at 6 Degrees Health. So, one thing I did want to add is that this process is seamless and at no additional cost to our RBP clients. So we'll perform a clinical review on high dollar claims and use those as a repricing with the repricing as well as with negotiations. So it's been a really great adjunct to 6 Degrees, and I think just an added benefit to our clients. So thanks for that. And Lindsay, we can kind of move ahead here. Go ahead and jump in. So I thought it'd be helpful to set the stage with what payment integrity can mean, and then drill down with like where our focus is at 6 Degrees. And then I'll talk through a case study in a little bit. So payment integrity is made up of many products, including prepayment claims editing, our clean claim or itemized bill reviews, and then everything from post-paid data mining to DRG validation, coordination of benefits, et cetera. So some of these are clinical in nature and some focus more on code edits. But there is a wide scope of payment integrity. So when we talk about payment integrity at 6 Degrees, we're really talking about our specific clean claim reviews. So sometimes it's kind of helpful to set the stage there. While all these programs are important, we know that clean claim reviews deliver the highest level of savings on the lowest volume of claims. So we have an average savings of about 15% or $18,000 per claim, which allows plans to save a lot of money with less disruption to the providers because it's small volume and easy implementation. Even though volume can be low, it really saves plans a great deal of money, just based on that 18,000 per claim. And I think we can all agree with skyrocketing medical costs that it's extremely important. We've seen catastrophic claims as large as $28 million So having these programs in place is essential to properly contain the costs and ensure the claims are paid the right time. So, right the first time. And you heard that correctly. That was $28 million for a single inpatient hospital claim. So with that said, I'll take a little bit deeper dive on the service that we offer. And again, as Heath said, please throw questions in the Q&A. Happy to stop in between slides and answer questions as they come up. So when I first started doing this 18 plus years ago, I'm a nurse by background. So as Scott said, I pretty much invented healthcare years and years ago. The concept of clean claim reviews was relatively unknown, and we were met with a great deal of provider pushback. So hospitals said you couldn't even look at a claim before it was paid. And once it was paid, you had to come on site and perform an audit, which greatly benefited the hospitals because audits are confined to reviewing the medical records and confirming that what was on the bill was documented in the medical record as ordered and provided to the patient. Essentially, as long as they had good documentation, the payer had no room to question their charging practices. So conversely, a clean claim review doesn't question whether services or supplies were provided to a patient or whether they were ordered. We're assuming that they were, but rather that the bill is free from defects and improprieties. And most states and contracts have clean claim language that outlines the claims must have all the necessary documentation in order to properly adjudicate and pay the claim, and they must be free from defects and improprieties. So what does that mean? It leaves a lot of room for interpretation. But the gist is they need to provide support for the UB claim, which is kind of the higher level. And what that means is the itemized bill detail, and the bill needs to be free from errors. This allows us to look at the bill in a different way in what we refer to as relational billing. So when we identify errors, we're not saying those items can never be billed, but rather that they can't be billed with other charges on the same date of service. And much of what we identify are line items that should be included in another more expensive charge on the same date. Again, we don't need the medical record and we're not looking at medical necessity. It's really a review of billing practices and compliance with the industry standard guidelines. Aside from the unique way we look at the claims, our program at 6 Degrees is really differentiated by the level of service that we provide. So not only do we have the expertise in the review itself, but we also manage any disputes and appeals with the providers, which gives us about a 97% uphold rate, meaning very little of what we identify on the front end is paid back to the provider through the dispute and appeal process. I promised Keith this wouldn't be too salesy, so I'm going to try not to add any too many more statistics on how amazing the program is. I did want to highlight, Scott, sorry, did you say something?
Oh, I had a question, but
Yeah, go ahead.
And I probably, if I would have reviewed the slide deck before this, I would know the answer. But if you're going to cover this, don't hesitate to defer. But I think I made the comment of clinical review, which and you're emphasizing more on billing review, and I think like my use of the word clinical is getting at more of who the people are that are doing the review. And are you going to speak to kind of the staff that's actually going through and looking at these claims?
I could not have asked you to do that better, Scott, which by the way, everyone, I did not. But Lindsay, if you go ahead and flip to the next slide. So no, this is really important. Our staff, so we have nurses, clinical reviewers that look at every single claim, and they have extensive bedside clinical experience as well as a tenure in reviewing claims. And this is really important because when I talk about relational billing, they have to look at thousands of line items on a claim and determine what is part of something else, right? So a hospital has an established charge master that lists a price for every single thing they could charge on a claim, 100,000 or more line items. And that's great, and we're not questioning that, but you can't always bill those things together because some charges are incorporative charges. They're a higher level umbrella charge. And our nurses know that, right? So our nurses understand the environment, what particular screws should be part of an implant that was already reimbursed. What types of things are routine for a nurse in the hospital setting, and why should those be included in the room and board? So it's critical to have nurses that are reviewing these claims. And there are a lot of IBR vendors in the space right now that are touting a fully automated itemized bill review in minutes. And I was at a conference last week and heard the term AI thrown around constantly. AI, we're applying AI algorithms, and they're spitting out these reviews. I think this is interesting, and I think it's a component, but we find that it's a combination of the nursing eyes on with the technology support that gives us the highest quality outcomes paired with the highest level of savings. We're just not seeing others getting this level of savings in terms of dollars that are also defensible because we're the experts. So we also have our own proprietary rules based on industry standard guidelines. I'm not seeing that a lot out there. We understand this, we understand the environment, and we've created the rules to be compliant with CMS. And we can customize reviews based on client policies, and we often consult with our clients to help them develop their own internal policies. So thanks, Scott, for bringing that up, and I can't stress enough the importance of having a legitimate clinical team who understands the environment and can support what we're doing. Any questions so far? Anything, Heath, I need to stop for?
There's a question that came in, just asking about your PI team and the makeup of the team as far as RNs go.
Yeah, so we've got, I think we're up to 7 or 8 RNs who are highly efficient in reviewing claims based on our, our platform that we've developed. So as I mentioned, it's kind of that combination of both the clinical review team as well as support from a platform efficiency tool. And we've got our rules built into that platform as well to kind of assist in both the speed and the outcomes of those reviews. But we also have a full team dedicated to appeal support, an awesome administrative team. I can't, big shout out to our team, which is somewhat small but mighty, and they're able to manage through a really high volume of claims in a short period of time. So hopefully that covered the makeup of the team. We do require at least 6 years of clinical setting prior to moving into this role. And again, I think that's just very important so that they understand the environment that the patient's in when we're talking through these claims and putting together the clinical picture, we call it, and reviewing the claims. So the initial bill charges on this claim were, again, I mentioned about $535K. We repriced that through RBP to $117K, and that actually included our clinical findings. So the way it works is we take the bill charge amount, we reduce it by the $100,000 that we found in errors, and then we reprice it through RBP to a multiple of Medicare. So after the payment went out, the patient received a balance bill of $418K. And we sent our clinical findings to the providers, again, really clearly outlining the $100,000 that we found in errors. We want to be very transparent with the providers and open it to questions, allow them to come back and understand what was removed from the claim. And so we send a very detailed report of those findings in hopes that we get a dialogue with the provider. We got the typical pushback from the provider that they didn't agree with the findings. They demanded 85% of bill charges. So we requested a meeting with their clinical team, which in a balance bill situation and someone from the billing office always gives them a little bit of pause or like, do we really want to go down this path? Like, what cards are they holding here? So they dragged that out a little bit. We did finally get a meeting with their clinical team. And once they reviewed the findings and we talked through it, they weren't able to substantiate their charging practices. So often the provider, again, wants to give us the medical records. They want to show the documentation that the services or supplies were given to the patient and they were ordered. But as I mentioned, we're not questioning that. So the dialogue we have is around their compliance with the billing standards. So What is their policy on what's included in their room and board charge? Why are they billing separately for nursing services? How could the patient have received greater than 24 hours of respiratory support on a single date of service? And surprisingly still, and again, been doing this a long time in similar programs, and their answers are still the same, that the items were ordered and given, and they've always done it this way. I often get the question about whether providers change their behavior, right? You're so transparent, you're telling them basically how to fix these errors, right? And the answer is no, they're not. Because unless every single payer is questioning every single claim in the same way, they're getting away with it. They're getting paid for these things inappropriately, depending on who the payer is.
Yeah, and Katie, I think this is a really important point. I should have listed this as an additional benefit in the reference-based pricing setting for PI, because you know, on the balance bill side of the equation, when you think about the origin of the balance bill, it is a contract claim that exists between the provider and the patient, right? The plan's not even a party to that. And it's basically the patient saying, hey, whatever my insurance doesn't pay, I'll take care of it. And, you know, layering in this kind of clinical component to question, like, that bill wasn't appropriate for
Right.
these reasons. It just, I think, provides a lot more substance to attacking these bills, especially on the high dollar claims. Obviously, we can't throw those kinds of resources at a $500 balance bill.
Right, right. Well, and it's very important when we're negotiating a balance bill to say, look, this $100,000, that's off the table. You billed it wrong. You can't, these are being disputed. You can't just turn around and bill the patient for things that are being disputed. And, I always like to say that, it'd be great to have a public demonstration of something like that and have the provider there to explain why they're billing for these things and why they're billing the average patient who doesn't even make $100,000 a year and passing these costs along that aren't even extra costs for the provider. So it is a really strong negotiating tactic.
Yeah.
And once we
Hey,
go,
Katie,
yeah,
there's a question that came in about the provider. Was this in network, out of network? Does it matter?
it was an RBP claim, so it wasn't attached to a network contract, but it doesn't matter. These reviews can be performed within a network or outside of a network, because if you really boil it down, we're looking for errors in the billing. So even if you have a terrific network contract, do you really want to pay 40% of erroneous charges? No, it doesn't make sense. The bill needs to be clean, and then you can apply the network discount. And so that's how we look at it across the board.
Thank you. A couple more questions. You want to take them now, or you want to roll on through this
Yeah, let's go ahead.
case?
One question or one comment on this. I think that's relevant to the in-network, out-of-network discussion. Over the years, some people will say, hey, you just can't do this on an in-network contract, right? Then the contract doesn't allow it. And my response to that is, there's always, in contract law, there's an implied covenant of good faith and fair dealing, right? It doesn't, you don't get to have a contract with somebody and then just completely screw them over and bill them for things that they didn't receive and say, well, you agreed to it. So, the networks probably would love people to believe that you can't push back on this stuff. The reality is they're all pushing back on it for their own book of business, right?
Right. They are. And we're, this is being done across the networks. The BUCAs are all deploying this type of program. So, the concept that this can't be done or that it's inappropriate, it just falls on its face anymore. And I have a lot of analogies, but I think about booking a hotel room, right? We're all travel for business. You book your hotel room, your nightly rate is $300. You go, you stay at the hotel, and you get your bill and it's $500. And you're like, wait a minute, I booked it, it was $300. And you look at it and there's a charge for your pillows and your sheets and the soap in the bathroom and the cleaning service and the, Bible in the drawer and you name it. This is the exact same thing. You've agreed to a price with the hospital or with the, in a network setting, right? And then they've just added on a bunch of extra things and hoped that you didn't notice.
Hey, one other thing too, we're getting a bunch of questions in, but there was one that came up and it was essentially somebody questioning the RVP repriced amount here is 117,000. The final settlement was 252. And essentially the question is like, that's way over the plan benefit. How is this a win? Right. And it's a very good question.
Yeah.
But the answer to this is that if you've worked with 6 Degrees Health, one of the things that's a little bit unique about us is that we are customizable. And so we have some plans who don't want to fight. They don't want to be very aggressive on some of these issues. They have a mentality to try to be, a little bit more subtle oriented. And we're not saying that's right or wrong. That is a client preference. There's pros and cons to that approach. But then we have the other end of the spectrum where many of our plans would have never agreed to this settlement, right? So, our RVP solution is not a one size fits all that, we are going to fight on every claim and never, agree to a settlement like this. It's really about having a consultative relationship with the plan and stop loss carrier and all of the relevant parties, and then carrying out, how they want to run their plan. So good question.
Yeah, and that communication, and I really didn't highlight that on these slides, but we are oftentimes the coordinator, right? Between the plan and the stop loss carrier and having these conversations. We know this is going to hit your stop loss layer. Let's have a conversation, right? And talk about where we want to resolve these. And so while it is outside of the plan benefit, our recommendation is ultimately this is a fairly good deal considering the size of the claim and the amount of time that this has gone on. And we want all parties to be on the same page and give you the options. And that's what we're here to do, is give the options, right?
Yeah. And the person that asked this question, they put in the chat, I won't repeat, well, I guess everybody can see who they are, but they said, we will fight to death on these claims. So, again, it's like, fantastic. We will be there to support you in that fight. And it's just, it really comes down to just acknowledging the difference in opinion when it comes to, risk tolerance at the plan level for these types of fights. And it is very unique to each plan. So we're happy that, you're a client, and we're happy to support you in the way you want to approach RVP.
I mean, the one thing I'd add to that is to echo on what Scott is saying is the ability to customize these things, and the payment integrity component to this gives additional negotiation leverage in the RVP environment. It also helps make sure you're repricing the things that should be repriced. But we also have a product called MediShield, which is a legal program that you can add into your RVP product that protects the member. Has been proven to be incredibly successful with reducing and or eliminating any additional payments above the reprice point. So there's different ways of going about this, and Katy's getting into obviously the payment integrity side of this and how we use it, but there's other ways you can fight these things too.
Yeah, and I mean, I think part of what Scott and I talked about very early on is like, this is about having, options and armament, right? Tools to combat what we're really all of us are about, and that is controlling healthcare costs and healthcare reimbursements to an appropriate level. So PI is not always a single answer. RBP is not always a single answer. Legal MediShield might not be, but to have all of these arrows in the quiver is going to make these plans that much stronger. And that's really our goal. They don't always work in one single path. Sometimes it's multiple different ways to sort these out. But really, this is just all about, you know, how can PI be a supplement to that? And I think we're finding that it's often very, very effective and very helpful.
So you got all kinds of questions coming in, Katie. You want to fire
Yeah.
through some of these, get caught up? I don't know where you're
Let's
at.
do-
in
yeah, I
the-
mean, I
the
really,
delivery of it.
really there. I was just going to talk about the results, and I think everybody saw them on the screen. And thank you to the last comment for the fast math. I have to be honest, I had somebody check my math on this because I knew somebody was going to be checking it as well. So yeah, what's next?
Okay. All right. Valentine's Day Q&A, fireside chat version. Do they always accept your adjustments? This question was asked about 15 minutes ago, so this goes back a few slides, but I think it's relevant to the PI reviews, and do they accept those?
So I'm going to answer with what might be a little bit shocking. They never accept our adjustments. And the reason is, if a hospital says, thank you so much for pointing this out, we have been billing incorrectly this whole time, they have to change their billing practice. If they don't, then they're knowingly committing fraud. So in a hospital situation, what happens is that they let it go. So they appeal certain things, they might fight harder with us on certain things. They'll exercise, you know, maybe level, and this is really in a more of a BUCA network setting. But at the end of the day, they have to demonstrate their compliance with the industry standard billing guidelines. And they find themselves unable to do that. And ultimately, they'll either stop arguing it, or this will push them to want to settle a balance bill. But they've got a lot of areas of recourse, and they exercise those, and we're the ones that work to defend it. We're the experts. But very rarely do they say, gosh, Katie, thanks so much for calling. This has been enlightening, and we'll be changing our billing practices.
And just to double click on that a little bit, it kind of depends on what you mean by accept, meaning what Katie's talking about. Are they going to put in writing that they agree to this? No, they're not, for the reasons that Katie just laid out. Are they going to accept it in terms of not pursuing it any further? Yeah, not 100% all the time, but that is really the more common outcome.
Mm-hmm. Hopefully that answered that.
Well done. Okay. Do you ever find that BUCA/ASO are, I think this might be a typo, caffeine overbilling?
Maybe catching overbilling.
Oh, yeah. So I worked many years with the BUCAs. Before I came to 6 Degrees, I was with Optum, and so the majority of them were my clients for this particular product. And they're all applying this for their fully insured book of business. So all of those claims are going through some type of prepayment itemized bill review. And in fact, the Blues Association has mandated it for their claims that anything over $100,000 has to go through this type of itemized bill review. With their ASO groups, it's often one of those opt-in or a buy-up type of service. And I have to say that I don't think they've done a very good job of both kind of marketing that they have this capability in a vendor, and explaining how this is helpful, how important it is, and getting the ASO clients to say, yes, this is worth opting into. But they all have it and they all do it. It's a matter of whether or not they're making it well known and making it available.
Mhm. And I have a little bit more of a sinister view on this. It's just my background coming out of a specialty network world. You can see why, like when it's your own dollar, how you would want to question these things. But if it's not your dollar and you are just a network that you're getting paid for people to access your network, your product is your relationship with providers. And so if you're beating them over the head constantly on these issues, that is contrary to, a good relationship with your provider. So I think there's some inherent just built-in problems with the way, this network traditional solution is set up, and there's just not a lot of incentive for networks to want the people paying for these claims to question them.
Right. It's easier to let them flow through and not disrupt their networks, but they will disrupt the networks for their money, to your point, Scott.
Better, yeah, you said it better than I did.
Okay. Catherine Brant, how do you apply the audit findings when a TPA and or provider has a no audit allowed provision? How do you reinforce the TPA to follow the plan documents or serve the agreement beyond their provider contract?
I'll start with the first question, which is a key question I've heard many times. The simple answer is that we're not performing an audit. So audit language in contracts is usually pretty overtly called out. And that is that you pay the claim and then you perform your audit by either coming on site or doing a desk audit, where you are allowed as a payer to review the medical record and confirm that everything that was appeared on the bill was ordered for the patient and documented as given. And as I talked about earlier, this is a clean claim review. We are not auditing to see whether or not their documentation supports these charges. What we're arguing is that the way they've combined these charges is not compliant with the industry standard guidelines. Going back to all of the unbundling, the duplicate charging, the markups that don't relate back to cost. Those are really billing compliance issues, and they are not about medical record documentation. Hospitals have been, and believe me, I worked in a hospital for years, very well trained, because everything you document is what gets paid. And that's really what's been hammered in the hospitals for the last 2 decades. But that's not the review that we're doing. And that's why it's important to establish there's clean claim language. And this is what it allows us to do pre-payment and avoid the audit altogether. So that's how we circumvent that language. How do you reinforce the TPA to follow the plan document? I'm not sure I understand the second.
I think
Maybe you do, Scott.
Well, I think what they're getting at is when you have a conflict between the plan document and the network contract, and this gets a little bit complicated, because I think there's one argument that the plan agreed to terms that are inconsistent with their plan document, right? And that's a little bit different issue than what this no audit provision that Katy just explained. So that's a really highly fact specific question that I think, for example, I remember back in the transplant days, we would have a case rate, and that case rate would include hospital, professional, and organ charges. And then, somebody had the brilliant idea to put in a plan document that, hey, we're not going to pay for organ charges. Right. And then they would come back after the fact and say, we're not going to pay for organ charges. It's like, well, you already agreed to pay a dollar amount that covers all of these services. And I think, you know, you start getting into state law, contract issues and all that. So I can't universally say this is true in every jurisdiction, but I think you're probably going to lose that argument in a lot of jurisdictions in terms of trying to enforce that plan provision.
Thanks, Scott.
Okay. Rolling right along. How long do claim reviews and or claim negotiations typically last?
Claim reviews are quick. We can usually get the claim reviewed within 3 to 5 business days. In terms of the negotiation, I think that's highly variable. In this particular circumstance, it took the better part of 2 months to come to a settlement between all of the conversations, clinical conversations we needed to have, exchange of information. You know, on average, I think it takes us at 6 Degrees about 30 days to settle a balance bill. But it is variable depending on, you know, I think the size of the claims will extend that time a little bit longer because they're going to dig in on wanting to keep as much of that money as they can. But I'd say those generally, you know, the review is fast, the negotiations and discussions take some time. And part of that is, I mean, frankly, we've probably all experienced it, just getting the right person at the provider to have this conversation and then getting a response. And so, you know, some of that just takes a lag of time between, you know, getting answers from the facility and then providing the documentation back that they're looking for. Hope that helps.
You want to take the one from Joel?
Sure. So the question is, at the time of service, members are required to sign the assignment of responsibility after insurance pays the bill. Does this hamper your negotiation leverage, and what advice do you have to educate members on what to do at that time? So I think what you're referring to is the assignment of benefits, which is essentially, you know, if you kind of get back and think about how a plan is set up, it's a contract between the plan and the members to provide them with a benefit for health coverage. And so, you know, if you don't have an assignment of benefits, then technically what should happen is the plan should be reimbursing their members for these expenses directly. And, you know, providers don't like that. Plans probably don't like that. And so they sign these things called assignment of benefits, which essentially allows the provider who doesn't have a contractual relationship with the plan to step in and say, hey, you owe patient X a benefit and they've assigned that benefit to me. And so you can just pay me directly. That does not, you know, really, that doesn't have anything to do with the contractual obligation that's created between the provider and the patient on a balance bill, for example. So, you know, just to throw some quick numbers, let's say you have a $100,000 bill and the plan pays $25,000. Okay, the question is, who's responsible for the remaining $75,000? A provider is, if it wants to be difficult, would take the position that, hey, patient, when you came to see me, you agreed in these terms that whatever your insurance didn't cover, you would pay the remainder. That's the balance bill, that $75,000. The assignment of benefits allows the provider to get the $25,000 plan responsibility payment. Hopefully did that make sense, guys? Or do I need to explain a little bit more on that? So, and you can, Joel, follow up if I misinterpreted your question, but that's, I don't, the short version is the assignment of benefits does not necessarily cause problems for, you know, any sort of leverage issues on negotiating balance bills.
Joel didn't like your answer, Scott. He said,
okay. So he said, not
I know
really.
you tried. You tried hard. It was a valid attempt, but
So maybe I
members
could
are
take it
forced
from
to
a-
agree to the responsibility of
Mhm.
what the plan does not pay for and
Right.
sign at the time of
Okay.
service.
Well, that's the balance bill, right? I mean, that is what Joel just described now that is the origin of the balance bill. That's a contract claim against the patient. And this is where you get into plans have different opinions on how you deal with that. Like, for example, Henry that spoke up earlier, his position is, hey, the plan paid the plan benefit, and end of story. And you may employ a legal strategy, like MediShield, for example, to have an attorney, fight on that particular claim on behalf of the patient, right? Because it's not technically a plan responsibility if your plan is set up properly. Contrast that to another plan that may not want to take a hardcore legal approach to that, and they may want us to get in and try to negotiate a settlement, which is along the lines of Katie's case study on the PI side. So there's a lot of different ways to deal with that, underlying responsibility, and it's a really complicated question. I mean, if it's an ER claim versus an elective procedure, I mean, there's so many variables to this. It's hard to really give a definitive answer there.
All right, we got 2 minutes. One question remains. What's your experience with ground ambulance transport fees? We have run into many issues. One example is a medical non-emergency transport, which the patient refused, but was still transported 40 miles, 6,500.
So from a PI perspective, the ambulance fees, air ambulance, ground ambulance should not be included in the inpatient claim. So our particular payment integrity service doesn't address that. We have solutions. I believe we still have some solutions for these ambulance charges. Heath, remind me if I'm not telling
We
you.
do. Some of them we end up running through RVP, but we also have access to ambulance discounts. But the tough part of it is those contracted components usually require some sort of pre-notification, which obviously can be pretty darn tough to do in certain circumstances.
Yeah, I mean, I think there's a reasonableness component to this, right? That can be argued if you're working to settle something like that. We can at least access, averages, average network discounts, typical expected charges for things to help with a discussion with the provider about how egregious the particular charges are. But again, I think it goes back to you have to get creative on some things, and it's not always just a one size fits all. And so sometimes you run across a unique problem and it requires multiple solutions to get to the other side of it.
All right, we are at the top of the hour. Let's go ahead and hit the last slides here. So there's Katie and Scott's contact information. Feel free to wish them happy Valentine's Day. We will be having our next fireside chat on March 20th with Chris Cooper will be joining us. We'll be getting into our MediShield product, which I think echoes right along with Henry's comments there about, if you really want to fight these things, what can you do? What's that program look like? And what are the legal ramifications? We have been running that very successfully. We use it on our own plan. I've used it myself. So join us on March 20th to learn more about that. Lindsay, we got any further slides past this one? Wrap this thing up. Oh, there's me. They know me. Move on to the end.
That's it.
That's it. Well, happy Valentine's Day, everybody.
Thanks,
You still got
everyone.
time to get flowers and candies. Make it happen.
Take
Scott,
care.
you can still redeem
Valentine's
yourself.
Day.
Yeah.
Hi, guys.
Bye, everybody.